Hi, my name is Naila Rabbani. I am adjunct professor at Qatar University, Qatar, and CEO of diagnostic startup, now working out of the UK. I would like to take you through the journey of development of blood test for autism. It started in 2018 when we published a discovery phase study, and now I am presenting clinical validation of plasma protein glycation and oxidation biomarkers, marker-based screening test for autism. And I would like to also explain what these biomarkers tells us. Autism is difficult to diagnose because there is no medical test available currently. Neuroscientists have developed behavioral tests to detect autism, but this is not used in a routine clinical setting because they require specialist expertise and are expensive and unpleasant. Clinicians find it difficult to diagnose autism since there are no biomarkers. The best window to diagnose is 18 to 24 months, but the current age of diagnosis is 4 to 6 years. This causes delay in diagnosis and impair intellectual and emotional development. Parents suspect their child has autism at a young age. They then often experience a diagnostic process that is frustrating, takes years, and is very emotional, both for the parents and children. So there is an urgent need for a medical test or a blood test for autism. Considering the clinical needs for a screening test for autism, firstly in the GCC, there are currently about 37,000 children and over 150,000 adults are living with autism. There are approximately 9,000 children born with autism per year in the GCC. Similarly, in Russia, autism cases are increasing. These are very conservative estimates. Currently, over 116,000 children and 425,000 adults are living with autism in Russia. In the USA, there are currently 2 million children and 7 million adults with autism. There are approximately 110,000 children born with autism per year in the USA, with 3 times the number of tests typically performed. So there is a minimum need of 330,000 tests per annum. For children, per annum for children, the CDC estimates about half of children by the age of 3 have not had their developmental disorder diagnosed, suggesting there are at least 500,000 children waiting for a test. Globally, there are 78 million people with autism and an estimated 1.3 million birth cases per year. In the EU, UK, and Japan, there is a minimum need of 250,000 tests per annum for children, and likely about 1 million currently waiting for a test. There is also an increasing demand for autism diagnosis in the adult population, which is difficult to quantify. In the UK, recent research suggests as little as 10% of the adult population with autism have received a diagnosis. So there is a long waiting list and high demand for increased expert diagnosis and screening. Our solution has been to develop a blood test for autism, When implemented clinically, this would improve access and timeliness of diagnosis to support early intervention and care, which could produce remission. Our blood test can provide robust screening, make more effective use of expert referral. Our test is also expected to be applicable to the adult population because our biomarkers are close to the ASD phenotype. Our blood test for autism is based on plasma protein glycation and oxidation biomarkers. In our discovery phase study in 2018, the minimum features of our diagnostic algorithm was 4 biomarkers. Although we measured 15 different addicts, the 4 features were plasma protein content of N-carboxymethyl-lysine, CML, N-carboxymethyl arginine, 3-CMA, 3-deoxyglucosone-derived hydroimidazolone, 3-DG-hydro-H. And the 4th, dityrosine. The first 3-CML, CMA, and 3-DGH are protein glycation addicts, advanced glycation end products, AGEs, and the last one, dityrosine, is a protein oxidation addict. These addicts occur on multiple sites of proteins, but mostly albumin in plasma. We measure the total addict of each type by quantifying addicts after exhaustive hydrolysis of an aliquot of plasma protein. I would like to explain now what these biomarkers tell us about the condition. In the discovery phase study, algorithm features carboxymethyl-lysine, CML, and CMA were both increased significantly in ASD. CML is formed partly and CMA is formed totally from glyoxal, a reactive metabolite formed in lipid peroxidation, which is normally detoxified by glyoxylase system. So this was an indication that there may be disturbance of lipid peroxidation in ASD. Prior evidence of increased lipid peroxidation in ASD was increased plasma malondialdehyde, MDA, and increased urinary isoprostanes described in the given references. The level of dityrosine was increased about twofold in children with ASD compared to typically developing subjects' control. Dityrosine is mainly formed by protein modification by dual oxidase, duox, an enzyme that cross-link protein oxidatively. Increased duox is linked to neuronal plasticity in response to metabolic or environmental challenge. These biomarkers may be mechanistic reporting on increased neuronal lipid peroxidation and neuronal plasticity. The only biomarker we found decrease in subject with ASD was 3-DGH, a glycation addict formed from the dicarbonyl metabolite 3-deoxyglucosone. 3-DG modified proteins have unexpected surface hydrophobicity and are unfolded. Their removal is mediated by activation of the unfolded protein response, UPR, a transcriptional system sensing the folded status of protein, activating when unfolded protein levels are abnormally high to clear them by proteolysis with concurrent stimulation of low-grade inflammation. Activation Decreased 3D-GH may be reporting abnormal activation of the UPR, consistent with this recent transcriptomic studies of post-mortem brain of ASD subjects found increased expression of chaperone gene for increased protein folding, reflecting increased activation of the UPR. So our blood test biomarkers report on disturbed metabolism may involved in the development of autism. We'll explain further later. Now the question you may have, why use plasma protein? Plasma protein is an accessible source of cumulative protein modifications, mostly 60% serum albumin, which has a half-life of about 21 days. The protein accumulates modification during this period and exchanges with albumin in the cerebrospinal fluid via lymph with a half-life about 5 hours. We measure multiple chemically defined plasma protein glycation and oxidation adducts, which are established clinical measures of glycation and oxidative damage. And these biomarkers report on protein glycation and oxidation in the CSF and CNS neurons, related metabolic and functional disturbances close to the ASD phenotype. The advantage of using plasma protein biomarkers is that they provide a cumulative measure of lipid peroxidation over the lifetime of albumin 3 to 4 weeks prior to sampling. Our analytical platform is stable isotopically dilution analysis, liquid chromatography, tandem mass spectrometry, LC-MS. This analytical technique is the gold standard reference technique for quantitation of small molecules such as amino acids herein. It has high analytical sensitivity and specificity, robust calibration, and good reproducibility. Additionally, LC-MS is often preferred for harmonization of analytic measurements between laboratories and is regarded by the FDA as an appropriate analytical technology for Class II laboratory-based test, such as likely applies to a blood test for autism. Pre-analytical processing involves exhaustive enzymatic hydrolysis. This is conveniently and reproducibly performed using a sample autoprocessor. We have described the method in detail in our recent paper in Essays in Biochemistry. We developed the method and have used it since 2003. Other research teams worldwide have applied it for their studies. We call this a technique Agiomix. For further information, please look at my website as well. In our discovery phase study, we had 38 children with a diagnosis of ASD and 31 typically developing children, mostly male and 5 to 12 years of age. An aliquot of plasma protein from non-fasting blood samples were analyzed by LC-MS. Analytical data were then used to train and test classifying algorithms. Total analysis time was 5 days. In the discovery phase, we analyzed 5 unmodified amino acids and 14 glycated, oxidized, and nitrated amino acids. Analytical data were analyzed for statistical significance of difference between cases and control. No single analyte gave strong, conclusive classification of autism cases and controls. So we applied AI machine learning using ensemble and sport vector machines method to develop algorithm with internal twofold and leave one out cross-validation repeated 10 times. We optimized classification accuracy and only retained features which were essential for maximum accuracy. As mentioned earlier, 4 features emerged as critical for optimum classification accuracy. 3 features increased in ASD, CML, CMA, and diatyrosine, and 1 feature decreased in ASD, and that was 3DG hydroimidazolone. In the receiver operating characteristic ROC plot, OROC was 0.94 and classification accuracy was 88%, with sensitivity and specificity exceeding 80%, the threshold classification criteria recommended by the American Psychiatry Association. The cohort size, however, is relatively small and validation in a large independent cohort was required. So further development of our blood test for autism required a large independent sample cohort appropriately powered. The aim of our clinical validation were to validate our plasma protein CML, CMA, DT, and 3DGH based diagnostic algorithm in a large independent subject cohort of children 5 to 12 years old. And the second aim was to evaluate the applicability of our diagnostic algorithm to subjects less than 5 years old in a large independent subject cohort. The clinical validation study was performed with subject recruitment in 2 cohorts in Qatar Biomedical Research Institute, QBRI cohort, and Baraka cohort at Sidra Medicine Hospital. Samples were acquired from a 3rd cohort in Malaga, Spain. Autism diagnosis was made by trained child psychiatrist using the reference method of Diagnostic and Statistical Manual of Mental Disorders 5 criteria, DSM-5, in the QBRI and Baraka cohorts, and revised Autism Diagnostic Interview ADIR protocol in the Malaga cohort. The combined cohort had 311 children with ASD and 167 children with typically developing aged 1.5 to 12 years, 478 subjects in all. Samples were analyzed with sample identity blinded from the investigators. Pre-analytic processing of samples was performed in my laboratory in Qatar University, with LCM-SMS analysis performed in the QBRI laboratory of Professor Paul Tonelli. Algorithms were trained and tested with 5-fold cross-validation. Here are the clinical characteristics of the combined cohort. Cohorts ASD cases were mainly male with 68% mild and 32% severe autism, assessed by ADOS-2 score. Score greater than 6 is judged as severe. The mean age about 5 years old, with 39% of the cohort 5 to 12 years old and 61% of the cohort 1.5 to 4.9 years old. Algorithm training and testing was done with this subject age segmentation. For the sample analytes data, plasma protein glycation and oxidation adduct levels were similar to those of children in the Bologna discovery cohort. Strong, significant differences for CML, CMA, 3DGH, and DT between cases and controls were found again, as highlighted here. For classification algorithm development, firstly, we looked at validation of the discovery study algorithm for subjects 5 to 12 years old. Again, protein modification features, CML, CMA, 3DGH, and DT only were required for classification accuracy with age and gender. Classification accuracy of 83% was achieved in an independent test cohort of 185 children, similar to that of the discovery study. Algorithm development was by the ensemble method. Note that the negative likelihood ratio was particularly low, indicating that the test provides strong, often conclusive evidence of absence of ASD, which in clinic implementation is the expected true outcome for most subjects tested. To date, our blood test is the only test validated successfully in large independent cohort. We also assessed if other protein glycation and oxidation adduct levels could improve the classification further, and found the best outcome came from inclusion of an average analyte level shown as AVE variable in the slide. When we applied the test to a broad age range, 1.5 to 12 years, the accuracy was decreased to 74%, but still holds promise of improved screening for diagnosis in the younger age group. Receiver operating characteristics plots of the 3 diagnostic algorithms are shown, reflecting the high classification accuracy of the algorithms with plasma protein glycation and oxidation adduct features. In the recent validation study, we also had the opportunity to compare levels of plasma protein biomarkers in the classifier algorithm CML, CMA, DT, and 3DGH in sibling pairs discordant for the ASD phenotypes from different families. The level of CML, CMA, and DT were increased ASD, and the level of 3DGH was decreased, but failed to reach significance for this sample size. Overall characteristic level of plasma protein glycation and oxidation biomarker are found in siblings discordant of ASD phenotype of the same nurturing family environment. This suggests ASD is not linked to nurturing and care in early childhood, but rather to initiating risk factor conditions in the first trimester of pregnancy. We were also interested to explore correlation of plasma protein glycation and oxidation adduct levels with severity of autism assessed by the ADOS-2 score. As the latter had over 7 different categorical values, it can be treated as a continuous variable. ADOS2 score correlated negatively with age and positively with plasma protein CEL and MGH1. The negative correlation with age likely relates to the accepted partial resolution of symptoms of ASD with age, including effect of behavioral therapy. Both CEL and MGH1 are formed from the reactive dicarbonyl glycation agent methylglyoxal. MG is formed as a byproduct of glycolysis and is increased with increasing fasting plasma glucose and insulin resistance, recently found to be common in ASD subject. This may suggest that severity of ASD is linked to increased exposure to MG, an interesting association deserving of further investigation. So we then looked into the literature and found that the insulin resistance is increased in ASD. In the study by Manco et al., insulin resistance was found increased in children with ASD. See data in the table. Plasma methylglyoxal is increased in insulin resistance, and plasma protein methylglyoxal derived glycation adducts correlated positively with ASD severity in our validation study. So methylglyoxal may be a risk factor for severe symptom of ASD. As well as diagnosing ASD, we would like to be able to alleviate severe symptoms with safe treatment. There is now potential role for dietary supplements which severe insulin resistance and decrease methylglyoxal. We know how to correct insulin resistance and decrease methylglyoxal clinically by treatment with glyoxylase 1 inducer. What is glyoxylase 1? Glyoxylase 1 are enzyme system which metabolizes methylglyoxal and glyoxal. So induction of glyoxal expression of GLO1 decreases level of reactive dicarbonyls, glyoxal and methylglyoxal, and thereby prevents increased CML, CMA, MGH1 and CEL. It also corrects insulin resistance, published a clinical study published in 2016 by Zhu et al. So what is a GLO1 inducer? It is a combination of highly tolerated dietary bioactive compounds, resveratrol and hesperidin, compounds found in red grapes and oranges. Effective doses cannot be achieved by diet only. So it increases GLO1 expression by activating cytoprotective transcription factor NRF2, which normally induced over 1,300 protective genes. So it may alleviate severe symptoms of autism. GLO1 inducer corrected insulin resistance in randomized double-blinded placebo-controlled crossover study, heads-up study, in overweight and obese adult subjects. It decreased fasting plasma glucose, postprandial glucose, and increased insulin sensitivity. It will likely do this in children may thereby alleviate severe symptoms of ASD. It is safe, effective, and highly tolerated. Maybe GLO1 inducer could be tried on adults with ASD and severe symptoms initially. coming back to the diagnosis, regarding other diagnostic approaches, other methods have been proposed. These are computer-based app of questionnaires and videos, MRI, visual attention, eye movements, polygenic risk score, transcriptomics, proteomics, and metabolomics. The current development issues of these alternatives are low classification performance, poor validation, high no response rate, poor subject tolerability, interference from comorbidities, and recruitment for expert centers. For genetic testing, it is considered that the current ASD polygenic risk scores account for less than or equal to 7.5% risk variance. I comment now on the IP status of our blood test for autism based on plasma protein glycation and oxidation. Our diagnostic test has patent approved in the USA and pending in the European Union, UK, and Japan. Regarding regulatory status, an application for FDA approval is under consideration. Clinical diagnostics partners are invited to develop the test towards widespread clinical offering. No blood test for autism has been approved to date. The likely classification is Class 2 in vitro diagnostic device (IVD) with special controls. Expected special controls for this test are clinical performance testing, sensitivity, specificity, positive predictive value and negative predictive value, which is being done, software verification, validation, and cybersecurity assessment, which has in progress, appropriate labeling instructions for use and clinical interpretation of output. It has already been established. A statement that device is not intended for use as a standalone diagnostic. So the blood test is a screen test. So we agree the blood test is a screening test for ASD. How screening for ASD would work without the blood test? Pre-screening is done by open access free online questionnaires, MChat RF for children less than 30 months old, and SCQ for children greater than, and others for children greater than 30 months old. Assuming a prevalence of 2.8% ASD in the general population, after this test, actual prevalence of ASD in positive test is only about 30%. So there is a high risk of children without ASD being diagnosed as ASD and a high risk of children with ASD being overlooked. Now, after application of the blood test, after pre-screening, the chance of missing ASD diagnosis decreases about fourfold with the blood test, and unnecessary referrals to child psychiatrist decreases about fourfold with the blood test. Increasing effective use of expert clinical time and care provision. Children development experts are seeking accurate screening before referral because they then see children with ASD, more effective use of their time, and parents and carer will benefit from the test because their children with or without ASD are not being misdiagnosed. So only 1 in 5 children approved for expert referral have ASD, and 3 in 5 have ASD overlooked. With our test, 4 in 5 children approved expert referral will have ASD, and 1 in 6 will be missed. So both our discovery and clinical validation studies have been published open access in Oxford peer-reviewed journal, Molecular Autism and Molecular Psychiatry. In summary, a simple blood test for autism has been developed based on assay of plasma protein, glycation, and oxidation biomarkers. Assay time is 30 minutes. Discovery phase of 88% has been validated in a large independent international multi-center cohort. Biomarker changes likely reflect activation of the UPR and neuronal plasticity in the brain in autism and response risk factors during pregnancy. With population prevalence of 3% applied after pre-screening, our test gives ensuring child development experts see positive cases and children with and without ASD are accurately diagnosed. We are now inviting and engaging with clinical diagnostics providers to partner regulatory approval and clinical offering of our blood test, and GLOW1 inducer may offer a potential treatment for severe symptoms of ASD. I would like to thank Qatar University for funding the project, my research team, Aisha and Dr. Warith, for their hard work and devotion to the project, and collaborators for providing the 3 sample cohort, Dr. Khalid Fakhro, Dr. Abir Al-Shamari, and Dr. Yolanda, and the computer scientist, Dr. Kashif Rajput, and Mr. Noman Arshid. And especially I would like to thank my long-term collaborator, Professor Paul Tonali, for his intellectual and technical support to the project. Thank you so much. For more information, I would like you to make a note of further information about autism blood test. Please check out my website, nailarabani.com. Further information about GLOW1 inducer, there is a glowcentrica.com web page, and glowvitality.co.uk is under development. And for information about blood test, follow us on website, Facebook, iDiagnostic on X, and on LinkedIn. And thank you so much for listening.